Assalamu alaikum. I am Professor Alaa Wafa, Professor of Diabetes and Endocrinology, and your Chief Tutor. Today, I need to discuss with you the second part of our discussion about thyroid disorders. We start this discussion by discussing the hyperthyroidism, and at first of my presentation now, I need to discuss with you some definitions. I think the majority of you know the difference between thyrotoxicosis and hyperthyroidism. So same clinical background, but we have some difference. Thyrotoxicosis means that the clinical syndrome of the hypermetabolism that results when the serum concentrations of a free T4, T3, or both are increased. But hyperthyroidism sustains the increase in thyroid hormone biosynthesis and secretion by thyroid hormone. And the first, the clinical syndrome, toxic problem, thyrotoxicosis. So we have her secretion of the T3, T4. Beside this, there is changes in the clinical background of the patient with the clinical symptoms and signs related to hypermetabolic state. But hyperthyroidism means that there is an increase of hormone from biochemical background rather than clinical background. Hyperthyroidism can be induced by many causes. So signs and symptoms can be caused by any disorder that results in increased circulation of thyroid hormone in the blood to the target organ in the muscle, liver, bone, and so on. Sometimes patients come with diffuse toxic goiter. Diffuse toxic goiter, so when you palpate thyroid gland clinically, you can find thyroid gland diffuse enlargement rather than nodular, and in this case we have two possibilities, either Graves or sometimes this diffuse enlargement related to thyroiditis. Then toxic nodular goiter. Sometimes this nodule is a single nodule called uninodular goiter or multiple nodule like multinodular goiter. Sometimes this enlargement related to painful subacute thyroiditis or silent thyroiditis or toxic adenoma, just single nodule with a toxicity, iodine and iodine-containing drugs and radiographic contrast materials, trophoblastic disease including hydatidform mole, sometimes a patient with hypothyroidism treated by L-thyroxine with overdose for long time, and that's falsely titrated. What about Graves' disease? Graves' disease, it affects up to 2% of the female population, and the majority of patients are the female with female to male incidence 7 to 1. It has a hereditary component. It occurs most often in middle age, most commonly in the 3rd to 5th decades of life. All of you should know that the Graves' disease have an underlying autoimmunity. So with this disease, the patient have antibodies against TSH receptors called TSH receptor antibody, TSH receptor antibody or TRAP, TRAB, TRAP, TSH receptor antibody with intrinsic activity responsible for 60 to 80% of thyrotoxic state. And as I said now, more common in women. And this diagram shows the pathogenesis of Graves' disease. Here you see activated beta cell that secrete antibody against TSH receptor, TSI or TRAP that utilize TSH receptor same like TSH itself with the same consequences with the amino acid. So that work on the thyroid tissue giving more manifestation and symptoms and signs of the adrenergic activity and the metabolic rate related to exophthalmos, tachycardia, and so on, as we discussed now. What about clinical manifestation? Here, Graves and autoimmune thyroid disorders with underlying diffuse thyroid enlargement with oversecretion of the T3, T4 that lead to suppressed TSH. Graves roughly may present clinically with one of the following characteristic signs. Exophthalmos. So you should now know that Graves always associated with the eye disease that's called thyroid eye disease or thyroid exophthalmopathy exophthalmos, protuberance of the one or both eyes. Also, this condition rather than eyes associated with the changes in the skin called non-pitting edema, or what's called pretibial myxedema, with the thickening of the skin, usually found on the lower extremities, and other vague main symptoms and signs of the hyperthyroidism. The main symptoms here, the hyperactivity and the irritability. The patient all the time are irritable, have an anxiety, heat intolerance, sweating, palpitations with increasing heartbeat, and fatigue and weakness, weight loss with increased appetite again. Weight loss, irrespective of the very, very increased appetite. So that's one of the common disease, weight loss with the increased appetite. So if you have a patient come to your clinic, say that, doctor, I have aggressive weight loss with the loss of appetite, you should think from endocrinal background of view with the thyrotoxicosis or diabetes as a hypercatabolic state. Diarrhea, polyuria, and changes in the menstrual cycle like oligomenorrhea and loss of libido. What about hyperthyroidism signs? Signs, that's tachycardia, sometimes tachyarrhythmia like atrial fibrillation, tremors, enlarged thyroid, palpated during examination, warm, moist skin, proximal muscle weakness, lid retraction or lid lag, plus breast enlargement with glandular background. That's called gynecomastia. And this diagram show in both sides. One, describe again clinical characteristic of goiter in gravis, and one, symptoms and signs. Here, if you just start to take a history from your patient and have a clinical examination, you can find your patient have goiter, thyroid enlargement with hyperthyroidism, then exophthalmos with localized myxedema and what's called thyroid acropachy, as we discussed now, then TSI or TRAP antibody or TSH receptor antibody, and that will clue to can deal with Graves' disease. On the other side, that's clinical characteristic in Graves' disease of goiter. So if you start to examine your patient locally with local examination in the neck, by palpation, you can find by palpation this character, diffuse increase in thyroid gland, diffuse, not nodular. So diffuse enlargement in a patient with these symptoms can give you a chance to diagnose Graves' disease. And with this diffuse enlargement, there is soft to slightly firm enlargement. Non-nodular, mobile, move up and down freely with the swallowing, and the swallowing is a very important tool during examination. Please, when you ask patient to swallow, please palpate well. So swallowing is the mandatory during examination of thyroid gland. Non-tender, without a prominent adenopathy, also with the stethoscope you can have a bruit or thrill. That means that the gland have a hypervascularity state. We have a different pillar to diagnose Graves' disease or Graves' syndrome. Her Graves' disease called syndrome due to presence of the change in the thyroid gland itself with enlargement of the gland and the secretion of the over amount of T3 and T4 plus eye disease, what's called thyroid eye disease, plus skin manifestation and the other. So that's syndrome. What about ophthalmopathy? Ophthalmopathy, patients have a signs of Graves are divided into two components, spastic and mechanical. Thus, you can describe this from pathophysiological background and the clinical background. What clinical impact of spastic and mechanical? So if you have a patient come to your clinic in early stage and ask you, please, doctor, help me, my thyroid bulged, my thyroid enlarged with a bulge in my eye, and that's proptosis or exophthalmos. So that's reversible, doctor, or not? So here you need to answer. You answer here according to the stage the patient come to you at time. If a patient come to you early and the IR spastic changes with a staring look, lid lag, and lid retraction, which account for the frightened phages. So if you start early to manage your patient well, here in this stage, your patient have a high chance to be reversible with a spastic eye disease. But if you start late, or patient neglect himself, or you are reluctant to start your active treatment and diagnosis her, the condition progress from spastic to mechanical changes. And this mechanical change is change in the lithobarbar tissue from lymphocytes, plasma cells, to the calcified tissue. So mechanical bulge of the eye lead to proptosis of the varying degree, lead to ophthalmoplegia, congestive oculopathy with some character like chemosis, conjunctivitis, periorbital swelling, and the potential complication of the corneal ulceration, optic neuritis, and optic atrophy, and sometimes in sight loss. So care of eye of patient with Graves' disease is mandatory and very important. And the simple test that's called a near reaction, and here you can make this test according. If you have objectives and become near to the eye, so you have squint as you see in this test. But in patient with exophthalmos that's unable to converge, so that's called lack of convergence with this eye. You see in this diagram or in this photo the eye of the patient central, so the patient have exophthalmos. How can we judge about the condition of the eye? So we should refer this patient to ophthalmologist who experienced thyroid eye disease or Graves' ophthalmopathy. So to examine and give us score for severity and score for activity. He start examining the patient and make scoring and search for what's called NOSPECS. NOSPECS, NOSPECS, and no signs or symptoms. O, only signs like lid retraction or lag or no symptoms. S, soft tissue involvement, periorbital edema. P, proptosis, more than 22 milli. E, extraocular muscle involvement with diplopia. And C, corneal involvement with a more advancement of inflammation called keratitis. Lastly, S, sight or insight loss, compression of the optic nerve with the sometimes blindness. And this could help you to judge. If you have still activity, not severity, you can start treating patient with the corticosteroid and then antithyroid. You can protect the eye of the patient. If a patient more severe rather than active, the condition differs. So the scoring system here with NOSPECS is very important to judge about eye problem. And that is a different patient presentation likely to be, and that's neonatal hyperthyroidism born to mother with Graves' disease. As you see, mother and her baby. That's different eye disease. The tethered left eye failed to move up and down towards and outward and maybe squinted, and that's problem weakness of the extraocular muscle. That's another exophthalmos lateral view. That's proptosis, that's this lag, and periorbital edema and chemosis of the eye, as you see this patient. That's ocular muscle palsy with weakness of the extraocular muscle, as you see. That's both thyroid eye disease and goiter. That's severe exophthalmos. Another item called dermopathy. Dermopathy usually occur over the dorsum of the leg or feet and is termed localized peritibial myxedema. And that's late manifestation and late phenomena with advanced age, with advanced disease. The affected skin area usually demarcated from the normal skin by being raised and thickened and having a pseudo-orange appearance. It may be pruritic with some itching states and hyperpigmented area. The most common presentation is non-pitting edema, but lesions may be plaque like nodular or polypoid one. And this photo of some patient, pink and skin-colored papules and plaque on the skin, as you see with the different three photos with the thyroid dermopathy, as you see here. And that's acropachy with affection of the nail bed. And that's the most marked index finger and thumb, as you see, that's thyroid acropachy. With the different changes, that is Graves' goiter with acropachy of this patient. That's clubbing of the finger, clubbing, and osteoarthropathy. That's onycholysis, as you see, onycholysis. That is this diagram gathering symptoms and signs of hyperthyroidism. As you see, commonly nervousness, tremors, hoarseness and deepening of the voice, mental disturbances and irritability, sometimes dry or sore throat, difficulty in swallowing, difficulty in sleeping, bulging eyes and unblinking stare, voice changes, palpitation, tachycardia, and enlarged thyroid again, menstrual irregularities and light period, sometimes amenorrhea, no menstruation, weight loss, irrespective of the very good appetite, frequent bowel movement till diarrhea, wear moist bowel, heat intolerance, increased sweating, sometimes sudden paralysis, first trimester miscarriage during a pregnancy with recurrent abortions, excess vomiting in pregnancy, family history of thyroid disease or diabetes, and so on. So how can you evaluate your patient with hypothyroidism? Evaluation of our patient here by different tools. First, ask for biochemically for thyroid hormone, free T3, free T4, and TSH. As you know, this patient with thyrotoxicosis have a very high T3 and T4 with suppressed TSH. So your patient have primary thyrotoxicosis, very high T3, T4, and suppressed TSH. As we discussed previously, in this patient with diffuse enlargement of thyroid gland with different symptoms and signs of the body with the thyroid eye disease and skin manifestation, you should ask for autoantibodies. The most common one is thyroid stimulating immunoglobulin, TSI, or TRAP, TSI, thyroid stimulating immunoglobulin, or TSH receptor antibody, TSH receptor antibody, or TSI, and other autoimmune antibody, anti-thyroglobulin antibody, and anti-thyroid peroxidase. Anti-thyroglobulin antibody and anti-thyroid peroxidase, anti-thyroglobulin antibody can be positive for all autoimmune disease, and the anti-TPO, anti-thyroid peroxidase, common in a case of thyroiditis. So when you ask for thyroid autoantibodies, here you can simply differentiate between autoimmune thyroid disorders. If you have patients come to you with diffuse goiter, TSH receptor antibody or TSI positive, so your patient now have Graves' disease. But if you have patient with the thyrotoxicosis, also diffuse goiter, with the anti-TPO positive, this patient have Hashimoto thyroiditis. Both cases can be presented early by thyrotoxicosis, but Graves positive TSH receptor antibody or TSI, but Hashimoto thyroiditis, diffuse toxic goiter with anti-TPO positive. Another tool rather than hormones and the antibody, thyroid ultrasound, and then thyroid scanning, and after that fine needle aspiration cytology. The thyroid ultrasound with high frequency sound should make a picture of the thyroid gland and give us many data about size of the gland. Is it nodular or diffuse? Can differentiate solid from cystic lesion, and give us scoring system, what's called TIRAD scoring, TIRAD, TIRAD scoring, that make us give us a chance to understand that with the stage 1 to stage 5, scoring 1, 2, 3, that's benign, 4, A, B, C, suspicious, TIRAD 5 mean that that's malignant, and other manifestation by ultrasound, calcified gland or not, vascularity of the gland or not, and thyroid ultrasound sometimes be a guide to take a fine needle aspiration biopsy. What about thyroid scanning? That's two-dimensional image. Give us a chance to understand iodine trapping within the thyroid gland. Radioactive material can be taken. The patient ingests radioactive iodine or technetium. After a time, usually 6 to 24 hours later, a gamma probe is placed over the thyroid gland to measure the amount of the radioactivity in the thyroid gland, and the values are then compared. Here, radioactive iodine, that is the probe of the gamma camera, and that is a typical curve of 24-hour radioiodine uptake in normal subjects and a patient with thyroid disease. As you see here, a percent of thyroid uptake with the radioactive iodine. Here we have three changes. That is hypothyroid, high turnover, hyperthyroid with normal, as you see here with the tracer of the iodine radioactive. That's normal results, as you see normal scan of thyroid. Here the iodine diffusely distributed in the normal uptake, and that is gravis. We have area of the high uptake surrounded by the area of the normal uptake. That is the single functioning nodule, that's hot nodule. That is different nodules with a high uptake called toxic multinodular goiter. That is the area of the lack of uptake called cold nodule, may be suspicious of malignancy and sometimes be a simple thyroid cyst. Lastly, fine needle aspiration cytology to give you understand the pathology. Is it lymphocytic changes? Is it follicular? It can give you chance to understand as benign or malignant. What about management of thyrotoxicosis? Here we have a three main line of treatment of thyroid disorders that start by the medical therapy, that is anti-thyroid drug, then radioactive iodine or surgery. So in this patient you have three main tools only to treat thyrotoxicosis, either anti-thyroid drugs or radioactive iodine or surgery. First, which treatment to choose? That's depend on patient preference and sometimes severity of the hyperthyroidism, evidence of complication of hyperthyroidism, is the patient pregnant or not, and the underlying cause of hyperthyroidism. Start treatment by discussing with you anti-thyroid drug that lead to slowing of thyroid hormone production, remission of the hyperthyroidism after 12 to 18 months course of treatment with these drugs. We have carbimazole, metimazole, or propylthiouracil. Carbimazole, metimazole, that's block iodination of tyrosine, so interfere with formation of the T3T4, immunosuppressive effect leading to decreased TRAP level, TSH receptor antibody level. Here, the anti-thyroid song is suitable for a patient with the Graves' disease. Propylthiouracil, it blocks iodination of tyrosine, decrease peripheral conversion of T4 to T3. So we have two important function here, block iodination of tyrosine and decrease peripheral conversion of T4 to T3. That's anti-thyroid drug that gives summarization of the this propylthiouracil with just give some complication of the anti-thyroid. Like first, one important, agranulocytosis. Granulocytosis lead to some immunocompromisation and usually with acute pharyngitis and recurrent tonsillitis, sometimes pneumonia, rash, hepatic necrosis, and some toxic hepatitis and cholestatic jaundice sometimes lead to arthralgia. So one main side effect, granulocytosis, second one rash, toxic hepatitis, then arthralgia. Rather than antithyroid, we have a beta blocker. Beta blocker here, propranolol, may be used to inhibit sympathetic overactivities, alleviating symptoms and signs such as tremors, tachycardia, until antithyroid treatment effects. Sometimes decrease peripheral conversion of T4 to T3, so decrease active T3 or diminish active T3 action on the receptor sites, and that's one important action. What about radioactive iodine treatment? Indication are Graves' disease, recurrent after surgery, or when medical or surgical therapy are contraindicated. One of the more complications of the radioactive iodination is the hypothyroidism that requiring evaluation of thyroid hormone. Should never be given to pregnant women. That's contraindicated to pregnant women. And that's radioactive iodine. Sometimes we give 10 to 15 millicurie. In toxic multinodular goiter or adenoma, 20 to 30 millicurie. That's absolute contraindication. Pregnancy and lactation. Pregnancy should be deferred for at least 6 months following therapy with radioactive iodine. It's advised to avoid radioactive iodine therapy in patients with active, moderate to severe Graves' ophthalmopathy. So patients with Graves' eye disease contraindicated to have a line of treatment with radioactive iodine that lead to more advanced thyroid eye problem. So treatment is medical, as you see. Commonly, medical treatment with Graves' disease and the two lines, radioactive iodine or surgery, can be used with the persistent cases. Her surgical removal of thyroid gland, that's called total or subtotal thyroidectomy, surgery is reversed for a special situation in Graves' disease. Sometimes you can select surgery as a line of treatment if there is a failure or side effect or non-compliance medical treatment. Patient compliance or adherence, very important. Patient with huge gland or retrosternal extension. Patient with the toxic multinodular goiter or suspicion of malignancy. Another important topic here is subclinical hyperthyroidism. You know, sometimes patients come to us accidentally with the changes in the TSH rather than normal T3, T4. In subclinical hyperthyroidism, our patients come to us by normal T3, T4 with the mildly low TSH. Again, patients come with the normal T3, T4 with the mildly low TSH. And this patient called subclinical hypothyroidism. Definition here: subnormal TSH level with normal total or free serum T4, T3, few or no symptoms or signs of hyperthyroidism. Potential consequences of hyperthyroidism here: sometimes patients with this condition have with long run changes decreased bone density with increased risk of osteopenia or osteoporosis, very important, and increased risk of cardiac arrhythmias, sometimes lead to tachyarrhythmia, like atrial fibrillation, especially in elderly. Increased risk of miscarriage in pregnancy, may or may not have obvious symptoms. And the question here: should subclinical hyperthyroidism be treated? I think that's an important question, and there is some controversy here about this problem. But should subclinical hyperthyroidism be treated? Yes, should treated. That's depend on the individual circumstances and presentation of the patient. Usually, you will treat if TSH is than 0.1. If TSH between 0.1 and 0.5, may initially observe only and follow for development of the overt hyperthyroidism, especially if younger and otherwise healthy patient. Should consider treatment of evidence of potential complication of hyperthyroidism. Likely patients start to have osteopenia or already patients have osteoporosis. Some patients with cardiac problems like atrial fibrillations. If frail or elderly, or if there is some symptom. That's all about thyrotoxicosis, and thank you very much.